Good morning, good afternoon, and welcome to Transforming Chaplaincy Celebration of Spiritual Care Week and to today's webinar, Developing Chaplain-Led Evidence-Based Interventions for Healthcare Workers. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could join us. Some housekeeping instructions off the top. This webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of that same control panel. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of today's presentation. With that, I'd like to introduce Chaba Salaji, Director of Transforming Chaplaincy. Chaba?
Thank you, Andy. Happy Spiritual Care Week to everyone. Thank you for joining us as we celebrate this week. We have a few webinars for this week. After today's webinar, we have two more. So you see the QR code and a link to follow for more information. We are also excited to start the Chaplaincy and Mental Health Care Research Network during Spiritual Care Week. And again, following the same link and QR code, if you scroll down, you can find more information and sign up for the research network as well. Another housekeeping item, I apologize for missing audience questions yesterday in our webinar, and we'll post responses to those questions to the same website you see linked here. It's my pleasure to introduce today's presenter, Tim Asset. Tim is a board-certified chaplain, ACP certified educator, and licensed marriage and family therapist. He has worked extensively with moral injury, spiritual distress, and post-traumatic stress disorder on research projects and clinical areas within the Veterans Health Administration, the Air Force Research Laboratory, Army Medical Command, and other private health systems. Tim completed a fellowship with Transforming Chaplaincy and is a Pat Tillman Military Scholar. Currently, Tim serves as a research health scientist at the VA Main Healthcare System, the executive director for the Physicians Wellness Collaborative, and the command chaplain for United States Army Reserve Legal Command. He is currently pursuing a PhD in health services research, policy, and administration at the University of Minnesota School of Public Health. And he's also a research assistant in the Minnesota Evidence-Based Practice Center. It's great to have you, Tim, here today. And Tim also serves as the co-convener of our newly formed research network on chaplaincy and mental health care. And this network's mission is to advance the integration of chaplaincy and mental health care through research and evidence-based practice across the continuum of care. Next slide, Andy. Thank you. We are also delighted to share two book discounts with you for Spiritual Care Week, and we are grateful to these publishers for making this available for us. So first here, you can use the discount code on the screen to receive a 40% discount when you buy the book Transforming Chaplaincy, the George Fitchett Reader. For over the past decades, George Fitchett has been a pioneering advocate for evidence-based spiritual care that can transform chaplaincy. And this book collects a key selection of his groundbreaking research and offers an ideal introduction to spiritual care research. Next slide, Andy. Thank you. And this discount code you can use to receive a 20% discount to purchase the book Evidence-Based Healthcare Chaplaincy, a Research Reader. And this book gives an overview and introduction to the field of healthcare chaplaincy research with wide-ranging topics. Next slide, please. I also want to highlight our ongoing fundraising campaign. Your support is more critical than ever, with more work to be done to elevate the field of chaplaincy through research and training. And if you find your webinars and resources valuable, please consider supporting Transforming Chaplaincy. We are at 70% of our fundraising goal for 2023. You can again follow the link from this slide. Thank you, and I'll turn it over to Tim.
Thank you, Chava. I will do the classic show my screen. And Chava or Andy, can you give me a heads up that you can see the
can see it.
PowerPoint?
Yes.
Perfect. Well, again, thank you for having me here today. I'm excited to talk about developing chaplain-led or interventions that chaplains collaborate with others, specifically those that become evidence-based through a process for healthcare workers. And I hope that Chava and Andy, you can monitor some of those questions. Feel free to interrupt me and ask questions real time if you think they're relevant. If not, we can plan to address questions at the end. That's me, which you already see. Classic disclaimer. Anything foolish I say doesn't represent the views of the United States Army, Department of Veterans Affairs, University of Minnesota, so on and so forth. And they reserve the right to punish me if I say anything exceptionally foolish. So some of our objectives for our talk today, we're going to talk a little bit about the emerging literature around moral injury and exposure to morally injurious experiences in healthcare workers. We'll do a little bit of very brief history on moral injury and where it came from and how it's viewed now in the space of healthcare compared to some of its origins more so in the service member and veteran literature. We're going to talk about an evidence-based intervention, building spiritual strength, that was initially developed for service members and veterans to address moral injury and spiritual distress and post-traumatic stress disorder, and how we've worked to adapt that intervention to better meet the needs of healthcare workers. And then from there, describe some of the ongoing research that's still happening with the old and the new intervention. And throughout this, I'll have some of this will be explicit, some of this will be implicit. I'll be talking about how chaplains can play a key collaborative and leadership role in the development and implementation of interventions for healthcare workers in this space. Okay, so I know most of us have probably heard this definition before, but in the event someone hasn't, I'm going to very briefly give a basic definition of moral injury as it's been viewed in the literature now for, well, since 2009 or the early 90s, depending on who you look at or how you think about it. But the term was originally coined by Jonathan Shea, a VA psychiatrist, in his work in the 90s with Vietnam veterans. And initially, moral injury was described as a betrayal of its right by someone who holds legitimate authority in a high stakes situation. And from there, that definition was expanded by Brett Litz and colleagues in 2009, and it really falls in three buckets, as it's often talked about in the literature. There's the doing something bucket, so I did or I didn't do something that violated my sincerely held values or beliefs. I was in a situation where I witnessed someone do something that violated sincerely held values or beliefs, and that betrayal bucket still exists. Generally, as Shay talked about, although there's some more nuance there. And this particular term was studied in service members and veterans, initially looking at, is this part of post-traumatic stress disorder? Do these things co-occur? Are they one and the same? And the literature in the last several years has really expanded to say that both exposure to moral injury and the we'll say the slew of negative things that can follow can very much overlap with post-traumatic stress disorder, but they can exist separately from post-traumatic stress disorder. That's a little further than we're going to go into today, but it is important to name that moral injury and PTSD, while they may be related, are not the same thing, with PTSD existing in the DSM-5 and moral injury does not. Additionally, within this wave of study of moral injury in service members and veterans, a number of evidence-based interventions were developed to specifically address moral injury in service members and veterans, which we don't have time to go into all of them today, but that will become relevant here momentarily. Okay, so we've talked moral injury very briefly as it started in the service member and veteran population, but today we're actually going to be talking about moral injury in healthcare workers. There's a lot of, again, more nuance that we don't have a ton of time for, but I think it's important to name parts of it. Interestingly enough, some of this real interest in moral injury in healthcare workers has happened pandemic and beyond. There was a little bit before that, as an alternative term to burnout. But there was a qualitative study, I believe, 10 years ago by Gibbons et al. That actually looked at experiences of moral injury in military healthcare workers or clinicians. So there was a specific look at healthcare folks in the military a decade ago. One thing that's important to note about moral injury when it comes to healthcare worker distress or well-being is that it is newer in the space, and that there are a lot of terms that have existed here for a long time. Burnout, of course, is one we've all heard of, that's existed for a long time. It's been well studied, and there's all sorts of negative associations with burnout in healthcare workers. And another term that predated even moral injury in service members and veterans was the term moral distress, which Andrew Jamison, I believe, coined that term in 1984. And there is a whole, we'll call it separate, but now merging part of literature around healthcare workers, particularly nurses and physicians, around these experiences of moral distress, which happened from a textbook definition is defined a little differently than moral injury and has been studied longer in healthcare workers. If we had more time, we could talk more about, well, is moral distress moral injury? Is moral injury moral distress? Which is what? We're not going to spend a lot of time on that, but it is important to note that both of those terms now exist in the literature looking at healthcare worker distress. And if you want to view a good, I would say a good summary of moral distress and moral injury that was just recently published, Brandon Griffin and colleagues just published a scoping review looking at recent literature on moral injury and moral distress in healthcare workers. And you can see on the slide, there are a number of empirical studies, actually a very high number of editorials, and a few other types of papers as well. And if you want to do more reading on moral injury as it existed just in the service member and veteran population, Brandon Griffin, same author, did a integrative review of moral injury in 2019. It's a few years old, but that 2019 paper and 2023 paper by Brandon Griffin are both very good resources if you want to kind of get a view of or a good summary of where the literature was, both for military and veterans, and now more recently with healthcare workers. Things to note about moral injury in healthcare workers. Again, it's a new term that there's a number of studies that have just come out in the last couple of years, but there's still a lot of development and research being done in the space to better understand potentially morally injurious events and healthcare workers. But one thing that Griffin noted in his scoping review is that there were very few interventions for moral distress or moral injury for healthcare workers that had good evidence behind them or that were even effective. And so that's part of what we'll be getting into today. We'll be talking a little bit more about the adoption of a specific intervention to meet the needs of healthcare workers in this space. Now, I know this is a webinar and I've been talking a lot, but I'll pause. Chava or Andy, any relevant questions come up so far that would be helpful for me to tackle before I keep moving here?
There's one question just came in asking that does Project Tahidu still exist within the US Army? Do you believe it is effective? TAHIDU.
I'm not familiar with what that project is off the top of my head, so I'm not sure. I can look into that though.
Okay, but that was the only question right now.
Okay, well, we will continue moving here then. Thank you, Chava. Okay, and so this is a conceptual model that was in the same Griffin paper that I noted, and what it's rather busy, and it isn't important to understand all of this, but I think it is important to at least acknowledge that when we're talking about, and you've heard me say potentially morally injurious events, PMIEs, there are a lot of factors that go into healthcare worker experience of these PMIEs. And you can see in this conceptual model, what we tried to capture in this space is that there is at the very top there, we have societal level elements, there's organizational level elements, there's interpersonal elements, individual elements, and then at the bottom, is kind of this event specific. An event happens, and then all of these parts of people play into, do they experience this as distressing or not? Because something that's important to note about potentially morally injurious events is it isn't a universal experience. What an event that one healthcare worker may experience as incredibly distressing and cause them problem for hours, weeks, months, years, depending on the severity of the event, may not have the same impact on another healthcare worker. And the reasons for that could vary significantly. It could be maybe these people come from different political points of view. Maybe they come from different religious traditions. Maybe they come from different cultures, races, or ethnicities that impact their view of morals and values that mediate some of these exposures in their work environment. So with that said, I do want to talk very briefly about some of this emerging literature in the healthcare worker space. And again, go to Griffin's 2023 article if you want the bigger picture, and you can see a lot more citations, but a few just to pull out here. Again, not surprising, a UK study found increased odds of mental health disorders, depression, alcohol misuse, and PTSD among healthcare workers with high exposure to potentially morally injurious events. And Marcy Weber conducted a study a couple years ago looking at exposure to potentially morally injurious events and different forms of psychosocial functioning. And what Marcy did was a latent class analysis. We actually talked about that paper in more detail in a previous Transforming Chaplaincy webinar, if you want to look it up and see more about that. But we found that there was higher levels of impairment in those that fell into the class that experienced the most moral injury or endorsed the most PMIEs across those different buckets that I previously mentioned. So the self bucket of doing or not doing something, the witnessing bucket of seeing someone else do or not do something, as well as that betrayal bucket. Other interesting pieces, I'm part of a project that's actually looking at moral injury exposure and its association with higher odds of turnover, intentions, and burnout. That one typo here, the paper isn't in submission, it's about to be in submission. We're going to be submitting that and hoping to get that out there because those are some very interesting findings. And another good paper to look at if you want to explore differences in moral injury exposure or experiences between service members and veterans, as well as healthcare workers. Jason Nuzma did a study roughly a year ago looking at differences in moral injury exposure between those two populations. And you can see on the slide there were some differences in endorsement of different types of potentially morally injurious events. But I would encourage you to go look at that paper. Again, it's Jason Nuzma if you want to read a bit more about that. Okay, so we've talked relatively quickly and whatever 10-ish minutes, however that's been, some background on moral injury, both as it began in the service member and veteran population, and then how it's gaining research and societal interest in the healthcare worker population. So now we're shifting to the part of the presentation where I'm going to talk about an intervention that was developed for service members and veterans, and then from there, talk about how we're working we did adapt this intervention for healthcare workers and some of the further study that needs to take place in that space. So what you see on the slide here is the Building Spiritual Strength intervention. It was developed by Irene Harris and colleagues. I want to say it's almost 20-ish years ago because they published their first study in 2011 and the trial took place before that. And what Building Spiritual Strength is, or what was and is, I should say, is that it's a spiritually integrated intervention to address trauma, moral injury, and spiritual distress. It was designed to be facilitated by both trained mental health professionals and chaplains. Ideally, this intervention would be facilitated by a mental health professional and a chaplain collaborating and working together. However, there are many cases where maybe that isn't feasible or possible, and individual disciplines can facilitate on their own with appropriate training within the bounds of how group sort of processes work and are offered within your given healthcare institution, prison, inpatient, outpatient, etc. And you can see an outline of the different sessions here. But BSS, as I'll call it, the acronym, is a group intervention that's designed to make use of people's existing belief system, faith, or spirituality. So what I mean by that is people come from different cultures, religions, spiritualities, and building spiritual strength is designed to work with anyone's belief system. That means that, and help them reconnect with their belief system and their values around right and wrong, good and evil, and processing some of the more difficult experiences they've had. And we do that through a lens of psycho-spiritual development, which I should have a slide here in a moment to talk more about. But to give you an overview of the intervention, it's 8 sessions. Sessions are roughly 90 to 120 minutes, with the beginning session being the very classic, this is our orientation to what it means to work together as a group, confidentiality, mandated reporting, and we actually spend a lot of time talking about how to talk about our beliefs with people that are different. And what I mean by that is we may have groups that are filled from people from multiple faith traditions or multiple belief systems. So we may have someone from a Jewish tradition, a Christian tradition, Islamic, Buddhist, Hindu, any variety of faith traditions or belief systems. We might have an atheist or an agnostic within the group. And building spiritual strength is designed in a way that people from any belief system can do the homework and the group material in a manner that's consistent with their belief system. So what do I mean by that? That means we might change our language as facilitators within the session to meet the needs of specific individuals in a group. And the group workbooks have a version that is more traditionally theistic, and there is a version that is more higher power, generic belief or spirituality, so that participants, no matter their belief system, can make use of the homework in a way that works for them. Sessions 2 and 3, we have some videos online which you can watch an example of that. That will be, we won't do that today, but if you want to look at that up later, we do what's called a modified empty chair exercise, where we allow people to share in several sentences what really bothers them, and then to receive feedback from group members and facilitators, either from the perspective of a higher power or as a fellow human, fellow veteran, fellow healthcare worker. And that gets into some of our developmental models around moral injury, which I'll explain in a moment. From there, there is reflection logs and meditative practices that people can engage in week to week as part of their homework. And then further sessions focus on theodicy and problem of evil. We look at different styles of meditation, prayer, centering, again, faith tradition or belief system dependent. And we spend a number of sessions on forgiveness and reconciliation, with the final session getting into consolidations of gains and identification of future resources. So that's a very brief description of building spiritual strength, and I want to say a bit more about the developmental model that goes behind it. So when we have experiences of moral injury exposure, what so many of us that have experienced them, either in military or healthcare context, is that we're often finding colliding value systems taking place in the same situation. And so what I mean by that is that in a military situation, you may have a service member that's faced with the rules of engagement telling them to do one thing, and their own personal religious or cultural familial belief saying to do something else. So no matter what that individual does in that situation, there are multiple right and multiple wrong answers, depending on which paradigm or belief system they prioritize. And the same is true for healthcare workers, particularly pandemic and beyond. When situations are faced with multiple right and multiple wrong answers to, if we think back to our moral injury buckets, to that self, witnessing, or betrayal, many of us in healthcare were attuned to a patient-centered model of care where we would push all of our resources to a given patient in a given time that was available. But the pandemic changed that. I don't know if I want to say temporarily or not, but to a more utilitarian model of care where we're having to make more specific rationing decisions about medicine, about equipment, about PPE. So that for many healthcare workers, that was a dilemma where there are multiple rights and multiple wrongs that can go on at the same time. And how we try to frame that in terms of how Dr. Harris developed building spiritual strength was the psychospiritual developmental model. And if many of you remember from seminary or other grad school or other places, follow their stages of faith, that's what you're seeing here. And that what we're getting to, that it isn't only the content of what we believe, but it's how we hold the content of our belief relative to difference. And for so many of us, we exist in that state, those stages 2 and 3 of this model, where we have very specific beliefs about institutions, authority, cognitive processes, what is right and wrong according to our value system, belief system, or faith. So then when we encounter something different than that, that creates some version of a disconnect or tension where we have a either or view of the world from our worldview or religion, and then we encounter something different and we're left with a dilemma that we have to somehow resolve. And for some folks, when we're in that synthetic conventional place, we aren't able to resolve that well with thinking with this either or thinking. And that's where Fowler's model can be helpful. And that's some of the background of the Building Spiritual Strength intervention, is that we're hoping to help people move to these stages 4, 5, and 6, where they're able to hold nuance and competing paradigms in ways that don't bring about excessive distress, either in the form of self-blame, other blame, disconnect from their higher power, faith tradition, or community. So again, we have a couple papers on this if you want to read more, but for time's sake, I am going to have to move on here. So to summarize building spiritual strength, what we've talked about what the intervention is, and the evidence base for this intervention includes 2 randomized controlled trials where we saw clinically significant reductions in symptoms of PTSD. The first trial, the intervention was facilitated by mental health professionals. The second trial, the intervention was facilitated by chaplains with specialized training. And since the publication of the second trial in 2018, we've been doing ongoing dissemination and implementation efforts, training chaplains and mental health professionals in the Building Spiritual Strength intervention. And you can see the website right there. Because this is government work product, these trainings are free to attend, and we offer them on a rolling basis a couple times a month. So go to that website, or you can email me if you want to get you and or your department connected with this training. And I know we haven't talked about health and strength yet for healthcare workers, but the training itself is the same. As you'll see in a moment, that the interventions are very similar. We just made a couple adjustments to help it better meet the needs of healthcare workers around some of the constraints they have in their work environments. But once again, I've been talking for quite a while and somewhat quickly. So Chaba or Andy, I want to pause us. Do we have other questions that I can attend to before I talk more specifically about health and strength and how that was developed from BSS?
A few people asked for the Griffin citation, and we put it in the Q&A. So if people want to refer to the scoping review article, and just a few, maybe just a few sentences is that how, that's my question, just kind of explain maybe to the audience about the RCTs and how, showing these outcomes is really significant, and just kind of the quality of evidence that you have generated here to support this intervention.
Yeah, very good questions. So the importance of conducting randomized controlled trials in this case, and I'll describe the differences between the two, is that when it comes to evidence-based practice, whether it's to treat a medical or mental health condition, or in this case, address a concern that we don't quite have in the DSM, is we want to show, is this more than simply a good idea? So the first randomized controlled trial, what it was called a crossover design, where in this case it was veterans. They were randomized to go through a BSS group or to receive treatment as usual. And then measures were given before the BSS group began. And then, again, we have randomization here, so that helps control for some forms of bias and other concerns, so that we found that those that were randomized to BSS, had more improvements in PTSD symptoms and increases in positive religious coping compared to those who had treatment as usual. So that means they either did nothing or maybe they were involved in something else. However, because it was a crossover design, those that received treatment as usual initially then received the BSS intervention later, and they saw similar gains to the first group that received BSS. And then from there, the second RCT was with an active control condition. So now we're going to still randomize, but we're going to see how does building spiritual strength do compared to another form of group therapy. In this case, present-centered group therapy. And we had the same interventionist chaplains in both cases, so there weren't differences in who was offering the groups at this point. And then we were able to look and see that building spiritual strength, both building spiritual strength and present-centered group therapy as offered by chaplains were effective in reducing symptoms of post-traumatic stress disorder as measured by the clinician-administered PTSD scale. However, building spiritual strength was more effective in reducing spiritual distress, which is it's again more complicated than we have time for. Some would say spiritual distress is a core component of moral injury and follows morally injurious experiences. However, spiritual distress also exists as its own term in the literature, so we have to be a little careful with that. But what this does by going through this RCT process, and I'll talk about some upcoming studies in this space, is that we can show that, hey, building spiritual strength did a better job than doing nothing, because that would be something important to know. And building spiritual strength did roughly an equivalent job as another group intervention around PTSD, and did a better job when related to spiritual distress. And this just gets into the, in order for us to disseminate and implement something, whether it's a patient-facing form of care, or in this case, a healthcare worker form of care, we want to be able to say that, hey, we generally know this is safe, and we generally know that this works for the things that we're trying to address. This is one of these important things I probably should have mentioned earlier, but one challenge that we face specifically with moral injury up until the last several years, and to some ways up until this current year, is that most of the measures only measured exposure to different types of potentially morally injurious events. So you can't do a measure of, well, how did someone's experience of moral injury change before and after intervention? Because their exposure to those events wouldn't have changed. The intervention can't change that. However, there are several newer moral injury measures that do measure beliefs and responses to moral injury that we can look at change. One is the Expressions of Moral Injury Scale by Joe Currier and colleagues. There's the MIDS, the Moral Injury Distress Scale, I believe, by Sonia Norman and colleagues. And then there's the Moral Injury Outcome Scale by Brett Litz and colleagues. Once I wrap up, I can try to get those in the chat if you want to look them up.
Thank you, Tim, for explaining the rigor of the evidence. There was one question came in as you're talking about how does BSS work for healthcare workers who have no spiritual or religious tradition? You may have touched on this, but was one of the interesting questions coming in.
Well, that's actually it's a good question to ask, because that gets into part of what we adapted. So from the letter of the law, building spiritual strength, while it's a spiritually integrated intervention, meaning we take into account people's religion, spirituality, or belief system, it is not prescriptive about any religion or any belief system. So that means that if a person without a religious tradition, atheist, agnostic, humanist, whomever, comes into a BSS group, that means that group will work to use language that's consistent with that person's belief system and assign homework and activities in a way that that person can do and that's consistent with their beliefs. That's a short and long way of saying what someone believes actually doesn't matter, because we will attune the homework and the group to be inclusive of different belief systems and religions. That said, and this is jumping ahead a little bit, part of the reason we called health and strength, the healthcare adaptation, health and strength rather than building spiritual strength, is because spirituality or religion are sometimes trigger words for folks that they just can't get past. So we actually intentionally changed the name so to remove a barrier to acceptability of the intervention, so that people on the front end aren't maybe feeling concerned about, hey, I'm a humanist, is this for me? Because it has spirituality in the title, if that makes sense. And that gets into a really important part around updating and adapting interventions to be acceptable to different populations and different people. So some really good question. But with that, I'll go on and kind of say a bit more here about, so I mentioned earlier from Griffin's scoping review of moral distress and moral injury in healthcare workers, there really isn't much out there in the terms of interventions for healthcare workers that have that are effective or have a good evidence base. However, there's a number of studies that have different numbers, but we're finding on the lower end 20%, on the higher end, some studies are showing 60 to 70% of healthcare workers endorsing exposure to some form of potentially morally injurious event. Now, of course, endorsing exposure doesn't equate with debilitating distress, but the point is that there are a large number of healthcare workers that are endorsing these experiences, and within that large number that endorse them, there is a smaller subset that is having significant distress related to that exposure. And it goes without saying, most of you probably work in health systems that have concerns with turnover, with being short-staffed. So in addition to we ought to care for healthcare workers and their concerns, there's very real health system implications to healthcare workers retiring early, choosing to work elsewhere, choosing to work less, so on and so forth. The other part here is, why would we want to adapt an existing intervention, is that interventions take years from development to adoption. So building spiritual strength, as I've talked about, has had 2 RCTs. One was published in 2011, one was published in 2018. So this has been going on for years, and there's still work to be done, so to speak, that to further and build the evidence base of this intervention. So starting from scratch is a very long process that can, again, when folks are in need right now, there's an element of we need to try to figure out something now. And the other reason why we look specifically at building spiritual strength to adapt is that because it can be led by chaplains or mental health professionals, and because it is a group intervention, we can make better use of our limited mental health and chaplaincy resources. And it goes without saying, but with BSS and Health and Strength and chaplains working to develop evidence-based interventions in general, interdisciplinary collaboration is key. So I've been working with Dr. Irene Harris, a psychologist, for almost 10 years, and the work that we've done couldn't have happened without having multiple mental health professionals, chaplains, health services research involved in the different projects over time. So part of this, again, speaking largely to chaplains, but the part of the question here is, why did we adapt building spiritual strength and intervention that can be led by chaplains for healthcare workers? Is that just as chaplains have a semi-unique role in military and veteran settings, that we really have a somewhat unique role in healthcare organizations, and that we are trained to work with different belief systems, religious, spiritual, non-religious, humanist, whatever it happens to be. And when we're talking about moral injuries and people's values and beliefs, those are important things to be able to talk about. We do look at bridging spirituality and mental health, which I think is very important. And we also are sometimes better resourced, though not often, but generally have more of a mandate or a dual patient and staff care role within our institution that varies more within mental health professionals. Sometimes that role is more of a either or with mental health professionals, where they're very specifically patient-facing, or there could be other internal or external constraints, whether they be organizational policy or availability of mental health professionals to work in this space. So here we have it, health and strength. So one of our questions already answered, why is it called health and strength? We removed spirituality from the title to help make this a bit more accessible or acceptable to people from different belief systems. The other things that we did for the adaptation is that you see we have 6 sessions instead of 8 sessions. And the reason we did that for healthcare workers is that 6 sessions is still a huge commitment, but it's less of a commitment than 8 sessions. because so many of the challenges healthcare workers face around staffing shortages is that there's limited times to even engage in healing and reparative activities, so that we try to reduce this by some degree. The other reason for reducing the number of sessions, and something that we now recommend, is so that chaplains and or mental health professionals could offer these groups, health and strength groups, within different health systems during work time. So that's not a specific change we made to the intervention, but it's more of a change in how we are recommending or offering up to people to how they may provide this intervention to meet those time constraints. And because if we think back to moral injury exposure for healthcare workers, a big part of that is that these are experiences happening at work that continue to happen at work. And that's a significant difference compared to military and veteran populations. If we're working with veterans, we're talking about events that happened in the past that a veteran is trying to make meaning of and heal from. Whereas with healthcare workers, it might be a past event, but that past event may happen on a weekly or monthly or quarterly basis. So that's where we also recommend trying to integrate these into work environments, because we're not only working with past exposure, we're working with present and future exposure too. So that's a little bit about how we adapted it. I will try to get this in the chat. We just published an article. Elizabeth Chaplain and I were the co-lead authors on that describe our adaptation in more detail. But getting back to what would the evidence-based work, simply taking an intervention. Now we can say we had military medics and health professionals in the Building Spiritual Strength, those first 2 clinical trials, but simply us taking that intervention and changing it is significant. We can't simply state, oh, this is just as evidence-based as it was before, or the evidence is as strong for this before. We need to do more research to better understand health and strength and building spiritual strength. And so that's where this work in developing evidence-based practice is a continuous improvement process. So 2 things that are happening now. One, with building spiritual strength, we're in the process of starting a hybrid type 2 implementation trial, where that's going to be a multi-site trial, looking at building spiritual strength being offered by chaplains on the one hand and mental health professionals on the other, and looking at differences in veteran experience of the intervention. As well as looking at some efficacy data too. It's like, is this still working? How is it working? Does it work differently between different facilitators? The second bubble or square we have here is that we recently got funding for a randomized controlled trial of health and strength for Department of Defense nurses and medics, and that will range from medic level to LPNs to RNs to nurse practitioners. So what we'll be doing is there'll be a couple sites, and military nurses and medics will be randomized again to this as a crossover design where they'll receive treatment as usual or health and strength, and then cross over to receive health and strength later. So that project, these are both just getting going, so there won't be any publications or reporting for probably at least a couple of years, but that's kind of how we're continuing this journey of building the evidence base, both for building spiritual strength and developing an evidence base or furthering the evidence base for its adaptation, health, and strength. A couple kind of final notes here is that health and strength and building spiritual strength are good group interventions to help people process difficult experiences, whether they be military or whether they be healthcare, but neither of these interventions are changing our health systems or our military systems. So that it's important to note that we've developed and are testing interventions to help people process difficult experiences. But another thing that Griffin and colleagues call for, as well as the National Academy of Medicine report from 2019, is that so much of the work in healthcare worker distress and well-being needs to be done at the organization and the system level. So we actually need to change the way that we do some of this work, and that might actually reduce exposure to these difficult, potentially morally injurious events. So again, that's not something we're talking about today, but it's something that it's important to name, that even in the development of these individual or group interventions, they don't solve the problem. They solve a part of the problem, if that makes sense. So we're getting to, it's about 1:45, so I want to open things up for more questions, but you can see my email right there. So things to note, again, BSS and Health and Strength are government work product. All the materials are free. The training is free. If you or your staff, whether chaplain or mental health professional, would like to get trained, please email me and I can get you connected with some of our rolling trainings. It's typically 6 to 7 hours by Microsoft Teams, and we offer those a couple times a month. The Diffusion Marketplace website link is there. It was also earlier in the presentation, and that has a lot of the references from this presentation today in terms of the randomized controlled trials of BSS, and we're working to upload some of these newer, the Health and Strength article, the Psycho-Spiritual Development articles I mentioned, those are all there too. So with that said, thank you so much for spending your hour with me today. I'm going to turn it back over to Chab and Andy for other questions that have come up or are coming up real time so that we can address those.
Thank you, Tim, for the presentation, and it's just such a needed resource and tool that you are not just developing but testing and generating evidence for its effectiveness. I think you already addressed one of the questions was about how does someone get trained in using the building strength or the health and strength modules. So if you give us both the references and the links, we can include that under the website that many of people, I'm assuming this call kind of ended up coming here and registering. So that way, if kind of as handouts, we can post them and we can post the training link as well for people. So it's just one click and go, hopefully. Anything else to add to the training that you wanted to?
Yeah, I would say email me or email Dr. Harris, preferably me. Dr. Harris will just forward it to me. But that would be and actually Dr. Susanna Kondrath, another psychologist, is going to be joining me in co-facilitating or leading some of these trainings too. So just get a hold of us and we'll get you, I believe our next trainings are November 1st and November 14th, or excuse me, November 13th, roughly 9 a.m. to 4 p.m. Central. And we don't have our December dates yet, but those will be set here probably within the week.
Yeah, thank you. And we have several more questions. One question is, has this model of care been provided to chaplains who experienced moral distress during the pandemic and corresponding political social discord? So has it been provided to chaplains as participants or receivers of this?
Well, the answer is yes or maybe. So in theory, I don't have the Diffusion Marketplace up, but we have roughly 17 VAs that have implemented Building Spiritual Strength nationwide, with 50 or 60 others that have been trained or are working to implement it. So I can say that chaplains have likely been in groups of this intervention, but well, no, I can actually think of a National Guard chaplain who did some dissertation work on offering this BSS to Army chaplains. So yes, so okay. I don't have that citation off the top of my head, but the short answer is yes and yes, both in the global sense as chaplains, as healthcare workers and military service members, and in the more specific sense too.
Yeah, and I appreciate the reminder in this question that we need it equally as other healthcare colleagues working in this space. The other question was about how would we define a healthcare worker experiencing repeated small offenses? I assume repeated small negative events and morally injurious experiences. Could we interpret that as becoming a large morally injurious experience or accumulating to probably a negative, larger, more substantive negative experience?
Yeah, well, really good question. So the moral distress literature in healthcare refers to this residue or buildup of these types of experiences over time. So that's one way that this has been talked about. A number of the studies for healthcare workers, I think the UK study I mentioned, I think it was Lamb et al., if my memory is working today, did note that higher endorsement of higher volumes of morally exposure or potentially morally injurious events was associated with higher distress. So that, if I'm remembering that study correctly, there have been some looks at volume of exposure probably matters. But similar to some things, that there's volume of low level, we could call it lower level disclosure or exposure, and more intense exposure, and that could matter too. So it could not just be volume, but also intensity of the case or how it goes. And I think those are questions that the literature answers a little bit, but will be probably hopefully more effectively answered with some of these new measures, the MIOS, the MIDS, the EMIS, that are going to be, really answering more specific questions around moral injury experience and following distress or symptoms compared to some of these surrogate measures we've needed to use in the absence of those measures being published.
Mm-hmm. The next question is about, can you say more about what the TRDC sessions look like? I think it was session
Four,
yeah.
well, we'll call it, it's session 4 in BSS. I think it's 4 in health and strength. But what we do there is that we introduce different views of evil and suffering from multiple faith world religions and just humanist belief systems. So if we think back to our psycho-spiritual developmental model, what we want to help people do is better integrate their beliefs about evil and suffering with others. So if we think about it, maybe someone, I won't name a faith tradition, but someone from a faith tradition somewhere has a view or a theodicy that God might, or their higher power, I'll be more generic, is punishing them for something, or they are to blame and unforgivable for something. Again, insert religion, we won't be specific. So that theodicy session for them might be them exploring, well, what are other views of evil and suffering within their same tradition? So to speak, because again, we're not converting anybody between belief systems. We're trying to help people better integrate and make meaning of their existing belief system, if that makes sense.
Thank you. And the next question is actually related to one of the questions I was holding to that. So the question goes, do you have resources, suggestions about getting the buy-in from the hospital administration? I think that goes back to actually implementing this intervention, because a lot of the chaplains on the call probably wonder about, how do I, get this up going, get buy-in from administration, from the hospital culture. And so that specific question, I also wonder about kind of barriers, facilitators of implementation you have seen so far in this training.
Yeah, well, and it's hard because there's, again, I would go to Griffin's paper. There's a little bit of literature that's looking at, if we look at things like burnout, occupational function, there's a little bit of cross-sectional literature in that space around moral injury and healthcare worker functioning. The paper we're going to be submitting, which I hope is published in 6 or 9 months, really looks at longitudinal impacts of moral injury exposure and burnout and turnover intentions. So in some cases, it might be dependent of your local leadership and what their language is. So for some, it might be just looking at prevalence. Hey, here's a study that shows 50% of healthcare workers are endorsing these sorts of experiences, and this is a problem. Or it could be simply talking, hey, what was our organization's turnover or retention rates of a given, whether it's nurses, physicians, things like that. Those can be helpful places to go if you can speak not just more generically, hey, I'm caring for our staff, but by caring for our staff, we may be able to alleviate some of these broader organizational concerns. And again, that literature doesn't exist, so you don't want to say, if you do this, that happens, but you're saying, if by doing this, we may be able to. We don't want to make promises we can't keep, so to speak.
And I think the next question is related to this. The question is, where is the opportunity for organizational change? You did speak to organizational system change that's necessary to address this larger issue than just at the individual level. And the question is, where are the opportunities for organizational change in this context?
Yeah, well, I would say some good places to look to kind of, again, it's 4 years old, it's pre-pandemic, but the National Academy of Medicine's report on clinician distress and well-being, or whatever it was called in 2019, named a lot of the different, it was kind of an aggregate summary of a lot of these things around administrative burden and really naming, here's organizational pieces. They also have a 7-factor model that talks about, I think there's 5 different organizational system pieces and 2 more individual or personal pieces. So if you Google Scholar, just look up National Academy of Medicine, 7-factor model, clinician, something like that, that'll give you a better sense of like, here's, bigger picture, some of these big name organizations, like here's how they're thinking about it, and here's ways that they're describing different potential areas for intervention.
Okay, thank you. And I did put the National Academy's website in the question box. So we have a time for a few more questions. Since the next question is, since the topic is newer and less known, and probably the individual asking the question wondering, is there a little bit of a fatigue with other terminologies such as burnout, compassion fatigue, and that kind of goes with the person asking, why moral injury and why now? Like, I wonder if there's different terminologies have been used, different concepts that addressing different yet overlapping aspects of distress, if I just kind of use an overarching term for that.
Yeah, well, this is me. There's some literature that might be in my head behind this, but I'm also speaking a little off the cuff. And I think others have spoken to this, like Pavlova. We'll try to get that in the chat. 2023 et al. They did a study looking at value discrepancies between healthcare organizations and what an organization or system saying and healthcare worker values, and how there's this mismatch. And where I'm going with that is, I think some of these other terms, burnout, compassion fatigue, whatever other terms we use, moral distress, I think there's an element of desperation here where people are throwing terms at a wall and seeing what sticks. And we can see, Griffin noted, there was this huge number of editorial and opinion pieces on moral injury, pandemic and beyond. And for whatever reason, that moral injury as a term captured national attention, both empirically, there's tons of empirical scientific work being done, but also just opinion pieces being done in ways that maybe burnout no longer does. So I think there's an element of what will get something to change, because Tate Shanafelt, Colin West, Lottie Derby, there's all sorts of folks out of Mayo and Stanford and Brian Sexton, Duke. There's all sorts of people doing really good work around clinician well-being and understanding stress, understanding burnout. And it is well read and it's well cited, but yet we see staffing shortages continuing and all this stuff. So I think that there's an element of desperation that goes into, well, hey, if people will jump on this moral injury train, and this might get us somewhere, I think that's part of it too.
There's another question about, do you have an interest in working with chaplains in other contexts, such as hospice, and expand research into other contexts and other than hospitals?
Well, yeah, I should say that. So building spiritual strength or health and strength has been offered inpatient, has been offered outpatient. There's a lot of different ways you can do that. It's been offered by telemedicine, and that goes for the patient-facing building spiritual strength and the healthcare worker-facing health and strength. So there's a lot of, I guess a lot of ways that this can be done in context that this could be offered that would include hospice and palliative care.
And the next question also relates to, I think, this theme of how this can be done. Would you suggest to start small with a pilot team, specific types of providers such as critical transport team, or go big as hospital-wide offering?
That's a hard question to answer, because a textbook answer would be doing some form of feasibility and acceptability based pilot trial. Like, hey, do people like this? Is this okay? That wouldn't have enough sample size to say, is this effective or not? So there's that school of thought, and then there's also this turnover stuff is a big enough problem that we need to do something bigger, go home. The challenge is if you're simply making something up and you put a ton of resources into it, you may find it doesn't work. That's a risk. There are some more, I would say, balance or in between implementation science approaches or study designs, like a step wedge, where you can say, well, we're just going to roll this out here in this unit. We're going to see how it does, update it, and then roll it out over here, and then roll it out over here, and kind of be taking measures along the way. But that's probably a short way to answer that question.
Yeah. And that would be your recommendation also, just for practical implementation without the research component, to kind of roll it out to units that are receptive and get started, and then maybe scale up from there?
Yeah. Well, and there are things like if you want to take something outside your institution, for example, you probably ought to have a trial or two behind a randomized before you start spreading something everywhere.
Yeah.
There would be. It doesn't say that it's wrong. I would say it's better practice.
Yeah. And I wonder, you mentioned training that's available. do you provide some ongoing support to facilitators as they start facilitating these groups? And do they have, like, if they have questions as they are providing this intervention?
Yeah, so we offer what we would call follow-up consultation or problem solving, because we have to be very careful. We're not providing clinical supervision for anyone in their context. We're really more of a, how can we help you troubleshoot, again, some of these barriers to implementing BSS or health and strength in your context. And again, the specific, this is how you do this intervention, is really where we stay, because we really aren't able to ethically or legally offer clinical supervision to folks in other institutions in other states and certain countries and so on and so forth.
And wrapping up our time today, I just want to say I really appreciate your and your team's work in this space, and it's such a good example of going the whole range of doing the intervention development, the testing, the trials, and really supporting implementation, very concrete ways of providing the training and help this intervention to be disseminated across a range of settings. So just want to express my appreciation for today's session and for this ongoing work that you have contributed to, and you being available to chaplains with questions and hopefully continuing the dissemination of this intervention.
Well, great. Well, thank you so much. It's been great to be here, and have a nice day, everyone.
All right. Thank you.